When most patients receive their cholesterol report, what they see is a list of numbers that appear simple on the surface: total cholesterol, LDL, HDL, triglycerides. But what I've learned over years of treating heart patients is that these numbers are often misunderstood in three very dangerous ways. And these misunderstandings are exactly why patients with acceptable reports still land up with heart attacks, stents, or bypass surgery. So today let me explain the three biggest mistakes I see almost every day in my clinic. The first and most common mistake is believing that a cholesterol report is normal just because it falls within a laboratory reference range, because lab ranges are designed for the general population, not for someone who already has heart disease, diabetes, high blood pressure, or a family history of cardiac events. And for a heart patient, especially after a bypass or stent, an LDL of 90 or even 80 is not safe, even though the report may label it as normal. Because scientific evidence clearly shows that plaque progression continues unless LDL is aggressively lowered, often below 55 or even 40 in very high-risk individuals, which is why many patients wrongly stop or reduce statins after seeing a green tick on their report, unknowingly increasing their future risk. The second major misunderstanding is focusing too much on total cholesterol or HDL while ignoring LDL and non-HDL cholesterol, because patients often proudly tell me, "Doctor, my HDL is very high, so I'm protected." But HDL is not a shield that cancels out high LDL, especially after heart surgery. And recent research has shown that extremely high HDL does not guarantee protection and can sometimes even mislead patients into a false sense of security, while the real villain, LDL cholesterol, continues silently damaging the artery walls, entering plaques, causing inflammation, and increasing the risk of clot formation. And the third and perhaps most dangerous mistake is assuming that cholesterol is only about food and therefore stopping medications once diet improves. Because while diet is important, cholesterol levels are largely genetically determined, especially in South Asian populations, meaning that even with perfect eating habits, many patients will continue to produce excessive LDL in the liver, which is why cholesterol-lowering medications are not a failure or a punishment, but a protective tool that stabilizes plaques, reduces inflammation, and prevents sudden cardiac events, particularly in the vulnerable months and years following heart surgery. What patients must understand is that a cholesterol report is not a pass-fail test. It is a roadmap that must be interpreted in the context of symptoms, surgery history, diabetes status, blood pressure, smoking, family history, and current medications, and ignoring this context is exactly how silent plaque progression happens despite good reports. So if you've had a heart attack, bypass surgery, angioplasty, or valve replacement, your cholesterol targets are very different from someone who has never had heart disease. And the safest approach is not chasing numbers but understanding risk, consistency, and long-term protection, because cholesterol control is not about one report, it's about preventing the next cardiac event before it ever happens.